So good morning, everyone, and thank you, Barb and Jen, for inviting me here. What I'm going to do here is, rather than going into data, I'm going to tell a story, what we have been doing for the last 5, 6+ years on this particular technology, and why I'm excited about it. And I think the most exciting part of this happened just a month ago, so that's probably the last slide. I'm going to stretch you till that, if you stay with me. So I'm Ravi Kolhe. I'm a pathologist by training. I practice molecular pathology. I used to practice a lot of things pre-COVID, but now I'm sucked into administration and do a little bit of molecular and cytogenetics at the Medical College of Georgia in Augusta, the home of the masters. These are my disclosures. Most importantly, I'm a healthcare provider. Anything I say here is not a medical treatment. So a quick introduction to OGM for people who have no idea what I'm talking about, but most of the slides will be our experience with optical genome mapping as a technology. Some of the work we have been putting together for the diagnostics, prognostics, and theranostics of heme and solid tumor, and what are future plans for that. So past, I would say 6+ years, been trying to figure out this technology. In the last 2 years, we have been aggressively working to bring this in the lab, and this goes to my personal interest of bringing new technologies in lab medicine. And we've been doing this for decades now, NGS, arrays, and I was talking to Barb and Jen over the breakfast, some of the things we really are trying to push the NGS boundaries. So hopefully, in the next few years, we will be doing whole genome for pretty much everything we want to do, and it will cost really less than $100. So for optical genome mapping, we have processed, I would say, 1,000+ cases now, and these are not just straightforward cases. We had a couple of instruments in the lab, and we took every clinical sample type we got in our clinical labs and try to see how we can do optical genome mapping on this. So we work with peripheral blood, pulmonary aspirates, amniocytes, products of conception, cell lines, your research cell lines, your lymphoblastic cell lines, and pretty much every solid tumors we could get our hands on through frozen room or OR. And then this has really helped us to standardize a lot of the protocols now for which we use and have published in clinical testing. And just to give you, in the last 2 years, even though we have processed a lot of samples, one of the things which we are able to make sure that all the QC metrics for all these samples, irrespective of sample types, we have achieved a pretty significant quality metrics which would be considered really good in a CLIA or CAP certified lab for clinical care. These are some of the selected publications, and I would say for the sake of this particular talk, optical genome mapping for oncology applications, the current protocols is probably one of the best paper or manuscript we have put together. It has all the secret sauce which we have figured out on processing samples for optical genome mapping and what we have learned. So when I was talking to you earlier about, I really like to get new technologies in the lab and not just bring in technologies and figure out how to actually take a technology, how to clinically validate it, how to clinically make it work, how to get paid for that particular test. And this is an exercise when we do in the lab, because I do get approached by a lot of vendors of new technologies. Hey, Dr. Kolhe, look at this. Why don't we'll just drop an instrument in your lab and give us a feedback? And there's a lot of effort goes in that, tech time, my time. So this is an exercise we do, and I think this is an exercise everyone should do. If you're going to bring a new instrument or moving from one instrument to another instrument, and these are very simple things like, oh, are we doing anything which is answering a clinical question? Is it something well established, gain in time, or just they say, hey, this is a great automated system. How easy is the sample prep? It's just more than acceptable turnaround time. And then most importantly, can get integrated in your LIMS, what's the footprint, CPT code, does it need FDA approval, technical assessment with Palmetto, and a whole bunch of other things. So each and every platform goes through, we put this thing in optical genome mapping, actually scored 0 on this. But we still were interested at the beginning. I mean, I was that much excited, I'm still excited about the technology to do this. So what is optical genome mapping? So if you haven't seen, heard, it's nothing but, one of the things which is, I would say, limitation or the strength is, it needs a fresh sample. Because what you're doing is you're isolating ultra long molecule DNA, and you're labeling them and imaging them. So unlike any other molecular technology, this is PCR-free, very low false positive, no sequencing error or filtering. Take your DNA, isolate it. The isolation is a very special technique, and I think that sometimes is challenging, or once you learn it, it's pretty straightforward. Label it and put it through these nano channels, and then basically you get an image, you digitize this like any other optical imaging, and then you get your data. The data is whole genome, so there have been a lot of metrics used, what exactly it is as compared to karyotype. Adam Smith from Canada has finally put together, it says it's 20,000 times more high resolution than your karyotype. So this is looking at your chromosomes through a Hubble telescope, if you're looking at, if you're more familiar with the karyotype. Where does it sit? There are so many technologies. If you're looking at a whole genome, so this is not a debate between a short read and long read. Again, you have your targeted fish, arrays for gains and losses. You have karyotype 5 megabase, and then the OGM pretty much covers a pretty significant landscape for structural variant. The gold standard obviously is karyotype, which is about 5 to 10. Then fish is targeted, but if you look at it as a perspective of cost saving, it could cover a pretty significant area for structural variants, especially array fish and karyotype. So this was our starting point, and just want to give you, before I start, these are the 3 clinically validated assays we run in the lab. So this is postnatal, this is prenatal, and heme malignancies. So these are all clinically validated. We do it for patient care on pretty much everyday basis. I'm going to come to the oncology part, but I know this is SERGG, so I'm going to give you some of our approach as well as validation on different prenatal and postnatal applications. So this is our products of conception. This was a pretty challenging stuff in the lab. We have a very robust reproductive endocrine group, which was started by Paul McDonough. And when we worked with his group, the problem of metal cell contamination is a major challenge. And we have this protocol in place now, pretty significantly improved one with optical genome mapping, which can help us overtake the MCC in examining metal cell contamination. This is a big project for postnatal, so we have done more than 1,000 cases across, I think, 10 plus different centers, which is looking at structural analysis in constitutional postnatal cases. And we have done a whole bunch of other work with different groups. So this is just to look at the Mullerian aplasia syndrome. This was during COVID when we looked at individuals who were affected severe COVID-19, how structural variants in them will affect, and went further ahead for looking at neurological complications and structural variants using optical genome mapping in COVID-19. So as I said earlier, when I personally would like technology to come in the lab is if it's brand new as optical genome mapping. We did a validation. We took that validation and went to AMA CPD committee and said, hey, this is a great assay. We really like to do for patient care. We got a PLA code at that time for rare disease. We took that PLA code, we went to Medicare and Medicaid and said, hey, we got a PLA code, we have this amazing assay, and we need some reimbursement. And at that time, I think $1,263 was assigned for us to do this assay in a postnatal setting. So this is just to give you some background what we've been doing, taking a technology and then pushing it through as much as we can in a postnatal setting. I know this is heme, sorry, this is oncology talk, so I'm going to talk a little bit more about heme malignancies. So when I was introduced to optical genome mapping, the first thing clearly came to my mind was heme malignancy. Because this is the samples we get fresh, your bone marrow aspirates, your peripheral blood, lymph nodes, and then isolating ultra high molecular weight DNA from heme would be pretty straightforward. So some of the challenges with the heme malignancies are most of the testing, especially myeloid, relies on karyotyping and FISH, and then the targeted panels is what we do NGS on 12 to 54 genes, some do 500, up to 500 genes. And then the challenge with the still current approach is the detection of structural variants and small variants, and it is still limited. And the reality of this is 45% of myeloid genomes still remain cytogenetically normal, and most of us, when we sign out karyotype, FISH, NGS, it comes to be normal, and when we know a patient who has 100% blast in their bone marrow, we were signing out their genomes to be normal. So this was such an easy application at the time. And if you look at the way the guidelines are changing, so pretty much from 17 to 22, and the new 26 are coming soon, all these guidelines are heavily genomic dependent. And we are not able to make justice to most of these cases which we are signing out. A lot of these guidelines are dependent on structural variants. And when we can't have FISH probes for each and every of these structural variants to be used in a myeloid malignancy, so it becomes near impossible to identify these subclassifications based on WHO guidelines or even NCCN guidelines. And we just end up calling them AML or AML with whatever we find on a chromosome and FISH or targeted FISH, which we do. And that's one of the reasons why there's a pretty significant push to move to whole genome sequencing. That's a whole different topic, but we were trying to find something in between. And again, not just the diagnostic guidelines, but if you look at the risk stratification, and it has moved significantly in based on structural variants, and in pretty much all the three groups of favorable, intermediate, and adverse. And we still are struggling to find all these structural variants on our regular karyotype FISH and type of NGS we do. Just want to plug in, there's a pretty significant effort internationally to look at OGM in heme malignancy. There's a big consortium. There are a lot of framework papers coming out, guidelines coming out. So if you're in this space, this is a group to watch for, at least outside the US, especially in Europe and Canada. They have moved to OGM as a standard of care for myeloid malignancies. And we have a different path because we have to figure out a CPT code and reimbursement and the stuff associated with US reimbursement system, but in Canada and most of the Europe, the labs have moved to OGM from karyotype and FISH for myeloid malignancies. So what we did here, so anytime when we get a new technology, we want to go through a thorough clinical validation. This is the GMD paper from my lab, where what we did was we looked at pretty much every subtype of it's not that clear, but every heme subtype is AML, CML, and plasma cell myeloma, and pretty much every phenotype in the heme malignancy we took. We got all types we got all types of samples. We got bone marrow aspirate, peripheral blood, lymph nodes, and we looked at different time points. We looked at what was the comparable assay, and how these structural variants would be validated. So in nutshell, we were able to validate each and every subtype of structural variant and its sensitivity and specificity. And in this particular study, which again took us 6 months to 8 months, 6 to 8 months to finish, and 1 year to actually bring this technology in a clinical assay. I think one of the most challenging aspects of this particular exercise was looking at what would be an LOD in a clear setting for different variant types, and I think this is an exercise which was very well received by the regulators, where we took each and every variant class and were able to figure out what would be an LOD, and this is how the imaging for different molecules looks like when you're signing out the cases. And we, for example, the translocation, we can go up to 5% allele frequency, actually can go up to 2.5% now with the new kits. And then we did this exercise for each and every variant class, very similar to what we do in NGS with SNV, DELS, and so on. And when we are looking at it, not only we were able to identify what we needed, but we actually identified a lot of new interesting stuff, especially in the translocation, which I'm very sure will be redefining some of these myeloid malignancies as we go forward, especially the ones which are based on translocations. So these are just to show RUNX1, KM2LA, FGFR1, and BCR-ABL, and the breakpoints we identified were brand new, and this was just in the validation setting. So again, we did the same exercise that we did with the prenatal people, a prenatal assay. We took this validation, went to the AMA-CPT committee, got the PLA code for OGM. This was the PLA code. Then we took the PLA code, went to Palmetto and said, hey, we got a PLA code, we want to test our myeloid and heme malignancies with this, we need a reimbursement. And for this particular assay, we are given a reimbursement of $1,850. So for some reason they separated out postnatal and heme malignancies. But the way we are doing it, I think I brought up whole genome sequencing earlier because there's a pretty significant push to whole genome sequencing for myeloid malignancies, purely because of the stuff we have been missing consistently on karyotype fission array. And what we were looking at is where would OGM fit in, and you can clearly see it pretty much is able to detect what we all were trying to do, even with whole genome sequencing on NGS, especially all these different variant classes, except obvious SNVs, you are able to identify most, if not all of them, in one assay. So this is the approach we proposed and doing currently in the lab, where we take a pretty significantly big assay called TSO500, which is 500 genes, and OGM, and we clinically combine these two assays for our heme malignancies in the lab. So this is just to show how a whole genome versus a TSO500 gene plus optical genome mapping actually is a lot more cost effective versus doing a whole genome at a very low depth of sequencing. Now I'm going to show you some of the case studies which probably are a lot more interesting than what I have been talking all across. So this is a case of myeloproliferative disorders where a karyotype detected a loss of Y, and the FISH panel was negative for any marker. So this is cytogenetic testing and molecular testing. And so loss of Y, and then molecular testing identified 3 variants, KRAS, 2 KRAS, and 1 TET2. And when we added OGM to this, we not only were able to look at the TET2, and this is a software called VIA, which comes with the instrument. And the good thing, or the amazing thing about the software, when I was introduced to it a couple of years ago, you can actually put the OGM raw files, the sequencing BAM files, and array raw files in the same view, and then look at entire case, chromosome by chromosome, on optical genome mapping, short read sequencing, and array. So we have, I think, 40 or 50 cases which we have done all the three, just to see how powerful or what are missing and what we can see in OGM. And this is like looking into the future where amazingly each and every technology has its own strength. The short read obviously has SNVs, the arrays with they're mostly copy number alteration. And then when we go to OGM, you can actually see compound heterologous events, especially a biallelic loss of TET2 with the deletion of one allele and a frame shift variant in the other. So this exercise was mostly to make sure that what we see in other technologies like short read and array, number one, we are not missing in optical genome mapping, but actually it strengthened what we are looking at OGM. This was another case where we looked at CLL. This is a CLL case showing several aberrations, but want to draw attention to chromosome 21, which is reported at like 2/21/21, and to this we perform a FISH using RUNX1 probe, and we can see three signals. We can see the three signals up there, which confirms the three copies of RUNX1's, hence chromosome 21. So when we were looking at OGM in this, we cannot see the chromosome gain of 21 here. However, we see the translocation between chromosome 1 and 21. And if we zoom in the chromosome 1 and 21, we can see the translocation, and there's a copy number gain in chromosome 1. And then zooming on the structural view of that particular translocation, we can see that there's a breaking in RUNX1 gene, which lead to explaining the signal with the FISH. And this is the reason why the OGM was able to correct both the karyotype and the FISH about the 21/21. Instead of that, it's actually 1/21 with a break in RUNX1, and that's the reason why FISH showed three copies. It's actually not gaining chromosome 21. One of the mind-boggling thing which we realized with multiple myeloma, especially the partners with IGH. So if you, I don't know if you how much you deal with multiple myelomas, and at some point we just give up and say it is partnered with something, because you can't really look at each and every partner by FISH, definitely not by chromosome. But the good thing about optical genome mapping is you really don't need to do any of the targeted FISH. It actually finds your IGH partner in one go. And then in this particular case, the FISH shows a gain of copy number of copy 4P, which is FGFR3, 23 out of 50 cells. And then in OGM, when we looked at more closely, it has a not only gain in FISH, but it was because of translocation in 4 and 5 with a breakpoint of 4P16 that overlaps the region of the FISH probes. And I think that's the reason why the FGFR gain was shown, and this particular breakpoint does not, the translocation does not disrupt the FGFR3. But our more interest in plasma cell myeloma was actually looking at CD138 isolated cells, because we do isolate CD138 that actually enrich a lot of our plasma cells. And our question was, did OGM do any justice for such a small number of cells post CD138 isolation? And actually it did. And not only did it help us a lot, and I'm gonna, without going into detail of what this is. So for example, this is your main bone marrow aspirate, the same case, and this is the same case with CD138 cells. And you can clearly see there's a difference in optical genome mapping in those two things. And it has helped us to figure out whether the changes, the structural changes coming from OGM, either are they coming from a background MDS or some kind of other proliferative disorder in the bone marrow versus coming from your plasma cells. And that changes a lot when we are deciding therapy for relapse plasma cell myeloma. So this was one of the things we showed, that even if you isolate CD138 cells, you still are able to do optical genome mapping. And this is what we are putting together as a going forward assay for our multiple myeloma, where we would be doing OGM on CD138 isolated cells. So this is another case where a karyotype identified a loss of Y, and the FISH was negative. And again, this is the same example. I'm trying to emphasize that when we do CD138 isolated, this particular translocation was lost, and you can clearly see this was happening in the whole bone marrow aspirate, and which basically shows that this particular abnormality, which was seen in the karyotype, was in the background MDS type marrow rather than the uroplasma cells, which were isolated. This is another myeloproliferative disorder where a karyotype showed a loss of Y, and the FISH panel was negative for any marker. Molecular testing identified a few other variants. I think this is I think this slide is repeated. Skip those. One of the most recent things which we are really pushing OGM is, can we make risk stratification using OGM? Because I think that's where it makes clinical difference. Whether if you combine karyotype FISH and NGS versus OGM alone, and what we did in this study was we looked at retrospective cases, I think 50 or 60 of them, where we had 3 to 5 years of survival, including even day 14, day 28 marrow, where we know what happened post chemo induction, whether there's a relapse or a remission on day 28. And cut the story short, we are able to reclassify some of these cases from very good favorable prognosis to very poor, and from some very good to intermediate, and that makes a pretty significant difference. And these were, again, retrospective, but we knew the clinical outcome on these patients. And this is in comparison to FISH, karyotype, array, and NGS. The OGM alone can definitely make from very good, favorable to bad, or intermediate to bad, or good to intermediate. And then this has a pretty significant clinical implication, especially if you want to decide transplant, especially without going into induction chemo. If you right at the time of diagnosis, if you know this is going to be a very poor or adverse, then these becomes cases where you can quickly take them to transplant rather than waiting for relapse. So I just want to end the heme part with a real case we recently signed out. I signed out, this is a 54-year-old female with 90% blasts in bone marrow. Again, very classic, and the reason why I got into OGM and heme, normal karyotype, negative AML FISH by NGS. This is what the diagnosis was. This was actually an outside case referred to us. And when we did OGM, this is how I sign out my cases, where you have the genome, the result, ISC, and nomenclature. We have two sections. Section 1 looks at NCCN guidelines, and the section 2 looks at NHS and WHO, excluding NCCN guidelines. And we found 2 clinically significant abnormalities: 11q3 rearrangement with 55% VAP, and EZH2 gene chromosome 7 deletion with 37.2% VAP. And this is OGM. And this is the circus plot of whole genome. This is the copy number alteration. This is that 11q3 rearrangement. And these are other abnormalities on the whole chromosome by chromosome. And just to give you a picture of how OGM, we sign out OGMs very similar to an array, karyotype, and FISH combination of reports. Any questions about heme? Okay, solid tumors. Again, what's the challenge? What are we trying to answer? So one of the biggest challenges in solid tumors is we're still looking at karyotype, FISH, and chromosome micro. These are the most commonly used solid tumor techniques and technologies. I'm not going to go in detail about them, but one of the major challenges with karyotyping is contamination of the contamination of the culture in the lab, or there's no growth or complex karyotype where it becomes too complex that we're not resolving anything. And this is everyday issue with solid tumor chromosome analysis in the lab. The problem, or the problem we are trying to solve is structural variants are actually extremely essential for prognostication in cancer patients, especially solid tumors. If you look at TCGA data or any data type which exists for solid tumors or even heme malignancies, most of, if not all, that data is coming from karyotype FISH and short-read sequencing, and there's hardly any structural variants in them. Everything is either SNV indels. Very few of them have some structural variant information, and hardly any of those, especially in solid tumors, are coming from chromosome analysis. It's mostly sequencing and some FISH. So the biggest, I think, the challenge or opportunity is to identify the structural variants in solid tumors. So the way I explain to our residents is, if you don't see anything, you're not going to quantify that. And then we have all these decades not able to see any structural variants in solid tumors, and we don't have any way to even quantify structural variants in solid tumors. There are a few, and I would say sarcomas, pediatric tumors, some adult brain tumors. The rest of the tumors, we hardly do any chromosome analysis purely because of the failures in culture. So these are some of the problem areas we've identified and trying to solve using optical genome mapping to look at structural variants in solid tumors. Again, this was the current protocols paper I talked earlier, where we looked at where we are giving out all the secret sauce which we have learned in the last 5 to 6 years. And the short answer is it's not very easy. And the reason with solid tumors is each and every tumor type is very different. So if you're taking a breast cancer, if you get a breast cancer sample, there's so much adipose tissue in the background and very small amount of actual breast cancer, which is good enough to make a clinical diagnosis on pathology, but you don't get that much of cells to do optical genome mapping or even karyotype analysis. Brain tumors, exact same thing. There's so much other tissue, but if you're looking at uterine or other tumor types where there's a pretty significant amount of tumor which can contribute to DNA isolation. So when you're doing optical genome mapping, the key thing is what percentage of the actual cells, nucleated live cells, which contribute to your DNA. That is the one simple metric which will determine whether you're able to do the assay or not, and that actually changes. So when we say 20 to 40 milligram of solid tumor is required, actually that doesn't make any sense if all the 40 milligram is adipose tissue. So you really have to go through, maybe make a cut and stain slide and look at how much of nucleated tumor cells are in there, otherwise you're going to get a lot of false positive. More recently, we were able to introduce standards of OGM testing in solid tumors in ACMG technical standard guidelines, which we were able to put together a pretty significant amount of information in there, which is going to help us, all of us, to see how we can process solid tumors on OGM. I want to give you a couple of examples and then move on. So this is just adult brain tumors or diffuse gliomas, and this is CAP algorithm to diagnose gliomas, and you can see how complex this is. Even with this complexity, there is no structural variance in this. So we are totally missing on structural variance in solid tumors, even at this level, because we were not able to successfully do chromosome analysis by karyotyping, and then a lot of the existing technologies like array and FISH really don't make any justice for structural variance at whole genome. So again, similar to heme, a lot of the diffuse gliomas, they are moving to molecular diagnosis, and most, if not all, molecular diagnosis are purely based, subclassification is based on structural variance. So what we did was we took a whole bunch of adult brain tumors, and I think this is somewhere in review, will come out soon in publication. The standard of care, gold standard technique which we use is an array oncoscan, and we took all the cases which we have run oncoscan on, and pushed them through optical genome mapping. So just to give you, this is the optical genome mapping on the top, and this is OncoScan on the bottom. And you can clearly see we're not missing anything which OncoScan can show. Just to give an example, this comparison between this one case where you're looking at structural variant by optical genome mapping, structural variant by OncoScan, and not only we are able to find 100% of the things which OncoScan showed, but we found a whole bunch of new things on optical genome mapping. So this is the exact same case, and you can clearly see how much more information we're able to capture by optical genome mapping. And not only it's just an information, it's actually critical, clinically important information, both in the diagnostic as well as prognostic setting of optical genome mapping. So just for this, so for example, this is the exact same case. Here, this is the most famous or most commonly used prognostic marker in adult brain tumor, the CDKN2A, where we can clearly see this is the mosaic deletion of 9p22, and when we look into more detail of that particular, we see a nested deletion in there, which also show unbalanced translocation between 7 and 9, and this high resolution, it shows also a copy number gain in that particular nested deletion. So these kinds of complex resolution we can only achieve by optical genome mapping rather than just doing an array. And this is, again, the same case. The advantage of optical genome mapping in the software is you can pick and choose the chromosomes you want to look at in your whole genome view, and then start dissecting in more detail about what is happening at the gene level in those chromosomes. For example, this is again the same case which I showed you earlier. MDM4 amplification, there are 14 copies on this. Not all of these were called by array or OncoScan, and these are all extremely clinically relevant and important prognostic markers of adult brain tumors. This is another case, again, 100% concordance between optical genome mapping and OncoScan. The interesting thing is we were able to identify there's something very important on chromosome 8, which was missed on microarray. Again, you can clearly see how much more information we capture on optical genome mapping as compared to our gold standard OncoScan arrays. Again, this is nothing against the technology, it's just a limitation of what an array can do versus an optical genome mapping can do. And this blue arrow on chromosome 8 is where we detected chromothripsis. And if you, I'm going to come back to that in a second. This is a uterine case. This is uterine endometrial endometrioid carcinoma. And here we're able to see translocation disrupting the NMT1 gene, which is again clinically relevant for prognostication. This is a breast cancer where we looked at there's a translocation disrupting GRB-G1 gene, again, clinically relevant information we need. So chromothripsis, this is a crowd which I don't need more introduction, but going back to that OGM case, so the glioblastoma case on the chromosome 8, when we just look at that particular chromosome under as a single chromosome, you can see the complexity of why a chromothripsis would occur on a chromosome 8. And this particular zoom in on the chromosome 8 shows multiple rearrangement, which probably leads to the chromothripsis. This is, again, this is FGFR1 gene rearrangement in the same chromothriptic event where you can see we are able to go a step further, not only identify confirming chromothripsis, but we can reconstruct the whole chromothriptic event using optical genome mapping by just looking at FGFR1, and this is how we are able to reconstruct the whole FGFR region on the chromosome 8 of chromothripsis, where we could map the two segmental duplication on P11.23 and P11.21 that harbor the FGFR1 gene, these two particular duplication, and and I don't want to go into details, it's boring, because chromothripsis is a separate project in the lab where we are trying to really understand what happens when we say something which is chromothripsis. But all this could only be done because of optical genome mapping rather than just saying a chromothriptic event on chromosome 8. So this is started at this, which has led to looking at in more detail, reconstructing the event and dissecting the chromothripsis itself. The last few minutes, I want to add another biomarker which we're very closely looking at is HRD. Again, HRD is an emerging phenotype which is making huge bends in particular tumor types, ovarian adenos, breast, prostate, and pretty much every other tumor type. The key thing is you really need to have an HRD phenotype to be sensitive to PARP inhibitor. At this moment, we don't have a consensus or standardization on definition, measurement, and reporting of HRD as a biomarker, and I think that's causing a lot of challenges. So what we did was we took all our cases of optical genome mapping and started scoring HRD versus the scoring on traditional methods, especially for LSD, LOH, and TAI. And as you can see, in all these years when HRD was coming up as a biomarker, all this information was not available. So you can't count what you can see. And suddenly we are seeing a pretty significant shift in the scores with the new sensitive technology, and I think which is going to make a pretty significant difference in patient selections for PARP inhibitor, because now suddenly a lot of these patients who earlier were not PARP, were HRD low, will be HRD high. So just to give you an example, this is a chromosomal microarray and OGM on the same case where we are looking at LOH or TAI. These are the different ways you calculate HRD. But suddenly, in cases where there's a lot of the things which the chromosomal microarrays miss, and the OGM starts looking at it and calculating, and especially the translocations part, which obviously you can't calculate, which you can see in the chromosomal microarray. So when we looked at the comparison between all our cases between chromosome microarray and OGM, there's a significant shift in HRD as a biomarker when OGM was used and versus chromosome microarray was used as a technique. So with this, I think at the beginning I said one of the most exciting thing about OGM happened a month or two ago, which is we finally were able to push AMA CPD committee, and I sit on that committee, to get a CPD code for OGM. So this is not going to be PLA code, and it's not going to be a lab-specific code. They're starting January of 2025. There will be a separate CPD code for optical genome mapping as a technology, like what we have 81455 or 81479 for molecular NGS. So finally we have reached at that point, and hopefully at some point in October, Medicare will put dollars on this, and we are really hoping we get something between $1,300 and $1,800, because this will be a general technique which can be used for prenatal, postnatal, anything you want to do with heme malignancy, solid tumors, and actually use this technique in clinic and patient care. With this is my summary. It basically is nothing but we are missing out on structural variants all our life. And I think it's time to get structural variants in oncology testing, but not only oncology, also prenatal, postnatal, rare disease, which I didn't even mention. We actually do a lot of rare disease testing on OGM. This is my lab, and some of collaborators with Bionano. And these are the people in the lab actually who make things happen. I'm just the face of it, and that's my family. Thank you.